I threw the objectives back in. Okay, this is kind of our guide. Remember, you can use that to kind of guide your study as well. I'm not going to go through those again though. The key terms. Okay. All right. So what did we say osteopenia is? What's osteopenia? Bone density. Yeah, changes in bone mass or bone density. Okay, and that's an important point. A lot of the issues that we talk about center on changes in that bone density. Okay, now is osteopenia to some degree normal? Yes. What are the normal occurrences for osteopenia? Okay, age-related changes. As we get older, we normally lose bone density. Okay, so that's not always an abnormal finding, but once it gets to a certain level, just like anything else, it becomes abnormal. Once we've reached that abnormal level, what do we refer to it as? Osteoporosis. Okay. So if I said I've got a patient that is 85 years old, structural changes have occurred, and this female patient has lost 2 inches in height. Is that normal? Abnormal? That's normal. Okay, that's part of that normal osteopenia. We haven't really reached the osteoporosis level at that point. Okay, usually 2 to 3 inches is what they consider. Up until that 2 to 3 inch mark, it's considered to be normal. All right, what are some of the other issues that kind of go with osteoporosis that would be abnormal? Okay, fractures, frequently occurring fractures, fractures with very little trauma or very little impact. That's going to be abnormal for sure. All right, any others? Okay, yeah, so changes in movement and range of motion. Now I'm not talking about, okay, it hurts a little more or it's not quite as easy to get to the mailbox and back. I'm talking about debilitating change. Okay, along with the osteopenia, some of that weakness or even some of that difficulty is expected. But when we have pain, severe pain with activity, if we have limitation of mobility, limitation of range of motion, those are not going to be normal changes. What's the function of the skeletal system? Okay, mobility. I heard support. Okay. Okay, so along with that mobility, yeah, it bears weight. All right. Protection. Okay, yeah, mineral storage. The skeletal system is our calcium storage center, right? What's the relationship? And this is something I didn't really hit a whole lot. What's the relationship between calcium and phosphorus? It's a seesaw. Okay. Now, the point in that is, yes, it's a seesaw, but it's a seesaw within the serum, within the blood. All right. So if I have increased phosphorus in the blood, so serum, what does that do to our calcium? It decreases it, but why? How does it decrease it? What does it do to the calcium? Or it causes it to go into the bone, right? It causes the calcium to be stored. Okay, so we've got All right, so the calcium comes into the bone for storage. All right. If we have a decrease in phosphorus, what happens to the calcium? Okay. As we have decreased phosphorus, our calcium is pulled from the bone. Okay. So, in this situation, there's diminished phosphorus levels. We have calcium pulled from the bone. What occurs, or what's going on here? What's our nursing concern here? All right, we have decreased bone density. So, what does that put the patient at risk for? For falls, for fractures, mobility issues. Okay, so there's going to be changes in that structure. All right, one of the other functions we hadn't talked about, bone marrow. Okay, what's the purpose of what happens in the bone marrow? It manufactures blood cells. Okay, so if we have diminished blood counts, all right, what could that be an indicator of? Okay, we could have a bone marrow issue. We could have an issue with that production as well. All right, when we're talking about joints, okay, first off, what is a joint? It's the junction where two bones come together, okay? So, space where two or more bones come together provides movement and flexibility in the body. So what happens, or what is the condition called? Well, let's go back a little bit. All right, I've got a synovial joint. When I have inflammation of the synovial fluid, what is that referring to? Arthritis, synovitis, but more, I guess more what we're kind of focusing on, arthritis. But what type of arthritis? If we have inflammation of the synovial fluid, or the synovium, that's going to be our systemic, and what type is that? Rheumatoid arthritis. All right. How does that differing, or what's the major difference between the rheumatoid and osteoarthritis? Okay. All right. That's very important to remember. Osteo is going to be your local arthritis or inflammation of the joint. Well, I don't know. The whole itis thing, osteo is local. It's a local inflammation versus a systemic inflammation, which you see in rheumatoid arthritis. All right, so connective tissue is important for support the individual organs and framework of the body, stores fat, transports substances, and provides protection, and also helps to repair damaged tissue. All right, so we've talked a little bit about this, but all right, I've got a patient that goes down for an arthroscopy. And what is that? Okay, it's a scope. Basically, we look at the joint from the inside. Okay, so it's a scope that is inserted directly into the joint and allows for visualization of the joint. Now, usually, they're not just doing an arthroscopy without at least an idea of something that they're wanting to do with that. So, they're not just going to look at it without really having a plan for hopefully correcting something. Does that make sense? You know, usually they go in to have it scoped. It's not just for the visualization and diagnostics. However, regardless of what they do while they get in there, our treatment is going to be the same, right? Well, unless they do something pretty invasive. But regardless, pre-op, that's going to be our role, pre-op and post-op, right? So pre-op, what do we need to do to prepare a patient to go to an arthroscopy? Well, MPO prior to the procedure, 8 to 12 hours. Ensure that informed consent has been obtained. Administer, well, so that's pre-op really. I mean, get them ready for surgery. Just your basic prep for surgery. Post-op, there's going to be some pain involved. So that's going to be not necessarily not an independent nursing intervention, but it's going to be a collaborative intervention. You got to make sure you got the physician order. All right, neurovascular status. As a general rule, if you have anything related to the bones, the muscles, anything with the orthopedic or musculoskeletal system, you have some type of alteration, you need to check your neurovascular status frequently. Okay? All right, so how are we going to assess the neurovascular system? So, those are good to know, but how are we going to evaluate these 6 P's? The pain, gas, scale, something like that. If I have a nonverbal patient, if I have a patient that is not really able to communicate, or maybe they're unconscious, something like that, how could I assess pain? Okay, facial grimaces. Okay, all right, vital signs, heart rate. So what vital signs? Okay. What's the matter? Go up. Heart rate. Okay. What about if I've got a patient with a broken leg and I go to touch that leg, what are they probably going to do? If they can, they're going to guard, they're going to scream at me, they're going to yell, they're going to say, hey, that hurt. Non-verbal, they respond. But look for those physical, non-verbal cues as well. All right, now, pallor. What's pallor? Paleness, so look at that. Look at the color. What about paralysis? How do we assess paralysis? Yeah, tell them to move something and see if they do it. So we're looking at evaluating for paralysis of the leg. You ask them to move the leg. Can you wiggle your toes? Can you move? Evaluate the degree and strength of the movement as well. All right, what about pulselessness? I'll take a pulse, right? Musculothermia? Yeah. You got to put your hand on the patient, right? Put your hand on them and see. Right now, if I go in and I've got a patient that's had a femur fracture, I go in and I put my hand on their foot and it's ice cold. What do I need to do? Okay, check pulses. What else do I need to do? This is not an amputee, so I've got another foot. What should I do with the other foot? Compare. If the other foot's ice cold and we know there's nothing wrong with it, it may just be that the patient's cold. Okay? But if you have the pallor, the poikilothermia, you've got pulselessness, all these combined, we got a problem, regardless of whether that other foot's cold or not. Okay? So you can't just take one and say, all right, everything else is good, but the foot's a little cold. That's not always going to be your not always going to be a test. But it's a part of that system. that talking about? Okay, sensation, numbness, the tingling, all that good stuff. How do we assess that? Yeah. Touch. Touch and see if they feel it. Also, a lot of times you'll have patients that, they don't necessarily have that tingling sensation just as they rest, but when they move, maybe they have some tingling. It's not always just a perfect indicator, but again, when you add all these together, you're looking for circulation. And you don't exactly have, well, I guess in this power category. What's another thing we need to really evaluate when we're dealing with neurovascular and circulatory status? Cyanosis. But also, what are we going to, when we pinch that toe, what are we going to have? I don't know if it goes in that pallor category, but regardless, you better do it. Okay? Evaluate cat refill. Make sure that you have a good circulation and blood flow to that extremity. And again, I've said it before, but if the patient goes in with a function, we expect to see it when they come out. Okay? Unless there's something that they've done purposeful, maybe they purposely, cut a nerve or altered a nerve, kind of like carpal tunnel. They've not they don't cut the nerve, but there may be some neurovascular changes that they do a nerve repair. They may deaden the nerve, or they may do something, but regardless, that needs to be reported. Okay? If it's a change, so they came back with function, and then now they're not really having all this function, that's an issue. Okay? All right. So we kind of jumped off of arthroscopy, but that's important, not just for post-op arthroscopy, but all of these conditions where you need to be evaluating neurovascular status. All right. ICE. Okay. Following an arthroscopy, they may use ICE. They may even use a CPM machine. I know typically the knee replacement is when they really like to use those CPM machines. Everybody know what I'm talking about with the CPM? Well, no, that's not the CPM. The CPM is that continuous passive motion device. I think it's the words for it. But basically they put the knee or the leg on a device that passively moves the knee in and out. Okay? They'll use it some with arthroscopy. Not quite as often, but they'll definitely use it for the patients with a knee replacement. Basically, that's doing continuous range of motion on that extremity. I'm not totally sure. I know they do sutures. I don't know if that helps kind of hold that in place. I don't know exactly the ins and outs of the surgery, but I would imagine it's got something to do with the sutures that they put into place. All right. Okay. Now crutch training. Yes. Yes. ICE is going to need an order. Well, the activity is going to begin after that sensation returns, as far as the arthroscopy. Usually, you probably are not going to have a ton of loss of sensation, unless they do some kind of local anesthesia or block. But the weight-bearing activity, now we may do range of motion almost immediately on an arthroscopy, but they're probably going to limit the amount of weight-bearing that they allow until that sensation returns. All right, but following, again, they're going to have, you'll have standing orders in a lot of cases. Okay, so the ice kind of falls into that standing order in most places, but you don't necessarily just throw ice on something unless you have that standing order. Does that make sense? That's a treatment that you have to have an order for. Yes. Ice would be one of those treatments that you would typically see if it's ordered. Yes. For test purposes. Yeah. It's one of those treatment regimens that it's not a nursing treatment. Usually within that 24 to 48 hour period. Now, elevation, I'm sorry. They may do heat, but again, don't focus in on that. Focus in on what the order is going to tell you. Okay. You may have a physician that says, okay, these are my discharge instructions that have that in it. But again, you have to have that. Does that make sense? Okay. All right. Elevation is going to be another big key here. Okay. Elevation. We want to limit swelling. We want to limit the risk for decreased circulation and changes to our neurovascular status due to swelling. Okay. So we elevate the extremity. Now, in a lot of cases, kind of like ice, you can ask the physician, hey, do you want us to put ice on it? If they haven't given you that order, you can ask for that. And usually they'll say, yeah, go ahead and do that. But again, kind of need that order. All right. Now, some of the things that you need to provide in your education. Discharge teaching. If fever begins more than 3 days, or even the edema continues 3 days post-op, and you may have some fever initially, it's just that general shock of the procedure, but 3 days post-procedure, they start developing fever, or they continue to have fever, or they have increased swelling, that's not relieved by the elevation. There may be infection. Okay, so make sure that you teach that patient what the signs of infection would be. All right, so besides the fever and swelling, what would you look for? Okay, so drainage, and what kind of drainage? Okay, usually some type of yellowish drainage. Now, if you just have a continuous or even an increase in the amount of drainage 3 days post-op, there's probably an issue somewhere. However, if the drainage is yellow or looks like it could be, you know what infectious drainage looks like, that's going to be something that they need to report. All right. What else? When I touch the knee, what am I going to feel? Yeah, we want it to be normal temperature. We don't want it to be warm. Warm, swollen, red. Okay. That's a sign that inflammation and possible infection is present. All right, let's see. Be familiar with your lab values. The calcium, phosphorus, phosphatase. We're not going to hit them a lot, but you need to be familiar with those norms. Also, sed rate. What is sed rate an indicator of? Inflammation. What about rheumatoid factor? Inflammation. What about C-reactive protein? Inflammation. All right. So those are our inflammatory markers. Those are things that they'll look for and use quite a bit in when dealing with orthopedics. When they're looking for that inflammation, the C-reactive protein, or the CRP. And then also blood counts. What are our blood counts going to indicate? The CBCs. Okay. Could indicate infection. Bleeding. Okay. It's another big one. All right. So bleeding and infection. Again, they'll use those quite a bit as well, particularly in orthopedic surgeries. Regardless of the type, blood loss is common. and lots of blood loss. Okay, so they really look at those to make sure that the patient is not bleeding. All right, osteoporosis, we've talked a little bit about that. It's a severe loss of bone density in which bone reabsorption is greater than bone growth. Okay. So we have increased reabsorption. So when I say reabsorption, what is that talking about? Calcium pulled back from the bone into the blood. So that's bone reabsorption. Okay? Students every time want to say, okay, reabsorption, that means the bone's absorbing calcium. No, that's not the case. Reabsorption is referring to the serum or the blood supply. So calcium is reabsorbed back into the blood supply. Okay? And when you have too much calcium pulled out without enough going in, then that's when you have the osteoporosis, once it gets to a certain level. They could. Absolutely. Now, it may be that they have a deficient intake of calcium as well. So if the calcium intake is not enough, they may be pulling calcium into the blood just to make it normal. Okay, does that make sense? So you may not necessarily have hypercalcemia. It's possible. But the body's, unless there's an abnormality where it just continues to pull regardless of how much is in the blood, it's probably just trying to make it normal. Because why do we have to have calcium in the blood? Why do we need calcium in the blood? Okay? For muscles, okay? Calcium is important in muscle contractility, right? If you don't have enough calcium in the blood, what happens? Yeah? You have cardiac dysrhythmias, because what is the heart? The heart's a muscle. We need calcium, a certain level of calcium in the blood so that our muscles can contract normally. Now, if we have too much calcium in the blood, what can happen? Our muscles are too, well, they're hyperactive. Okay? The threshold for contractility is much lower, so they're more likely to contract. Okay? So I guess it's hyperexcitability. Twitching. Yeah. Twitching, tetany. That's kind of what they're referring to there. So we have too much calcium in the blood. It makes our muscles too quick to contract, or inappropriate contraction. All right. That's an awful picture, I know. Do what now? Yeah. I mean, that's... Yeah. Well, okay. So what's happening when we're not using our bones? What's happening when we're not active? Our muscles, or not our muscles, but our bones will start to break down. That calcium starts to leave the bone. So what could we encourage a patient that's able but not as active, and they have low calcium density or low bone density? So they need what type of movement? Weight bearing. Now, not high impact, they don't need to go try to play a football game, but low impact, and that helps to improve bone growth and bone mineralization of calcium. Okay, does that make sense? All right, so osteoporosis, you have too much reabsorption without enough bone growth. All right, some of the other factors, and we talked about this a little bit, but genetics, some of the things you can't really control. Thin, small frame, postmenopausal women, Caucasian or Asian race, sedentary lifestyle, cigarette smoking, excessive alcohol use, increased age, and insufficient calcium intake. When is bone growth at its highest level? Okay. At younger ages. Pediatric patients, that bone density, that's when that we have the bone density storage. Okay. As we age, what happens? It slows down. All right. So if you've got a patient that's a 65-year-old female and you have reduced bone density, is that, yes, we're going to encourage calcium intake, we're going to encourage calcium supplements and all of that goes along with it, but is the bone growth going to be at the best level at that point? We want to encourage the calcium stores early, during childhood, during early adulthood, okay? Because it's much easier for the bones to replenish that calcium, those calcium deposits at that point, rather than waiting until it's almost too late. Not completely too late, but it's a lot harder for the bones to regenerate at that point. Okay, that's usually when we treat it, but that's, as nurses, we want to encourage calcium and dietary changes early before it becomes an issue. So any patient that falls into these risk factor categories, you want to encourage those dietary changes now versus later. All right, some of our other signs and symptoms of osteoporosis, obviously the pain with activity or lifting, problems with balance, decline in height from vertical compression, kyphosis, and then also degeneration of the lower thorax and lumbar vertebrae on radiographic studies. All right, what's the reason, or what's the problem that causes postmenopausal women to lose their bone density? All right, reduced estrogen levels. Okay, what is estrogen? How does estrogen impact calcium? Does it create? Does it make the bone grow? No, it prevents it. Okay, it prevents the reabsorption of the calcium. Okay, estrogen. No. Bones don't reabsorb calcium. Reabsorption of calcium is coming from the bone into the blood supply. Estrogen blocks or prevents, slows is a better word, slows that calcium reabsorption process. Okay? Yeah, if we have increased movement of calcium out, the calcium levels can go up. Now, I think one of the questions a while ago was, is it going to be abnormal? Well, if you have a diminished level in the serum and the body responds by pulling calcium out, then that may just make it normal. Okay? Potentially, yes. Potentially. The best way to prevent that bone loss, or I'm sorry, the calcium loss, bone density loss, is to increase calcium intake. Okay. So if we have sufficient calcium, and now one of the other factors you've got to consider is absorption of calcium. If the body is not using the calcium that we bring in efficiently, if it's not absorbing as much calcium as it needs, then you may have inappropriate removal as well. So just because you're bringing it in doesn't mean your body's using it. Okay? Yeah, it's still abnormal. If the value, if it's over, if the serum calcium level is high, then yeah, that's abnormal. All right. I think we're kind of moving into stuff that's not quite as essential, but you do need to understand this process. Okay, you need to understand the process of losing bone density and how that. Well, okay. So how is that going to affect things? We have excessive loss of density in the bone. Risk for falls, risk for fractures. Yeah, changes in mobility. All right. So these are the things you want to encourage. For one, what's the key nursing diagnosis for osteoporosis patient? It's going to be safety. That's going to be your focus. Okay. Safety to prevent falls and fractures. Okay. Also, want to provide recommendations for worsening or prevention of the worsening of the condition. All right. So we would encourage, again, with an order. Well, dietary changes you could encourage anyway, but the high calcium, vitamin C, and vitamin D diets, along with protein and iron. You encourage low impact, weight-bearing exercises. Encourage good use of posture and body mechanics, and avoid cigarettes, alcohol, and coffee. And also maintain adequate fluid levels or fluid intake to prevent renal calculi. All right, well, walking versus running. Which one's high impact, which one's low impact? Walking is going to be your low impact, so you encourage walking. Okay. Swimming, is that a low impact, or is that a non-weight bearing? There's not a whole, I mean, there's probably some, but you take away the gravity in the pool, and you've lost that weight bearing activity. Okay. Resistance, yes. Yes, resistance would be, as long as it's slow, slow resistance, not, we're not trying to throw up huge, bench press maxes or anything like that, but, yeah. All right. So swimming is not a, it's a low impact, or it's non-weight bearing. More of a non-weight bearing. You lose that resistance. Yeah, cardio, as long as it's, again, low impact cardio. Swimming is non-weight bearing. That's a non-weight bearing exercise or activity. You talking about swimming? Well, yeah. I mean, it's non-weight bearing, but it is low impact. But it's not. If it's non-weight bearing, it's not going to encourage bone density growth. So we don't want to encourage that necessarily. We want stuff that's going to encourage bone density growth. All right. Jogging is high impact. Walking would be encouraged for an osteoporosis patient. Yeah, walking in the mall. These are the guys and gals that are speed walking in the mall every Saturday and Sunday morning. All right. Y'all may have passed them on your Thanksgiving Black Friday shopping. Just getting in the way, I guess. But anyway. All right, some of our collaborative. Oh, sorry. Yeah, if we have increased calcium, serum calcium, what's the body going to respond with? Well, it may try to put some back in the bone, but the kidneys are going to try to clear it as well, right? So if we have increased calcium in our urine, kidney stones. Kidney stones can form. All right. Some of our collaborative interventions, and you need to know these. Okay, you need to be familiar with these medicines. All right, biphosphonates, Fosamax. Okay. The nurse should instruct the patient to take with a full glass of water at least 30 minutes before meals and remain upright for 30 minutes after. All right. Fosamax inhibits bone reabsorption. All right. The next category, selective estrogen modulators. This is dealing with this whole estrogen process. They mimic the effects of estrogen to reduce bone reabsorption. So Avista, Forteo, these are going to be your estrogen, it's basically the estrogen supplements. Basically, they're just going to do the same thing that estrogen would in its normal form. All right, osteoarthritis. Again, it's a mechanical breakdown of the skeletal structure. Okay, this is not a systemic issue. This is basically wear and tear on the joint. All right. If you remove the padding, the shock absorber, and also the lubricant, this is what can occur: physical changes to the skeletal structure. Again, this is not a local, or this is a local issue. This is not a systemic autoimmune response, which is what rheumatoid arthritis would be. Not usually, because you still have that synovium. You still have that lubricant there. All right, so what are the signs and symptoms? What do we expect to see if we have an osteoarthritis patient? Pain. All right, when does the pain occur? All right. Yeah. Usually the osteoarthritis patient, initially the pain is going to occur with activity. Now, as the disease progresses, that pain can change. It can change to where they'll experience that pain even with slight movement or at rest. All right, what else? Okay. Yeah, the nose and nodules. Okay, that's it. Those nose and nodules, Bouchard's and Heberden's nodules. Those are the two different types you'll commonly see. Yeah. Bouchard is B-O-U-C-H-A-R-D. Heberden's H-E-B-E-R-D-E-N. Heberden's Bouchard's is down here. Heberden's is going to be up. More difficult. All right, this is a pretty good example here on the severe osteoarthritis. What do you notice about this that would lead you to believe osteoarthritis? Exactly. There's some bilateral issue breakdown here, but it's not symmetrical. Okay, one side is worse than the other. Okay, probably going to be a right-handed patient. She's probably using that right hand more. All right, we've also have limited range of motion. So changes to our range of motion in that localized extremity. So if we have a osteoarthritis in a knee, that's where you're going to see that limited range of motion. It's not, if it's just in one knee, it's not going to be bilateral changes in the range of motion. All right. Also, skeletal muscle atrophy can occur. Inability to perform ADLs. All right. Why would that be? Why might there be a change in their ability to perform ADLs? Yeah. If you've got change here, limited movement or sensation or function of that hand, not sensation, but function of that hand, yeah, there you go. Change it. They can't open a can opener, or they have trouble opening up cans, or whatever else. Got to have the little rubber easy opener. Sensitivity to temperature. Also humidity. Like I said, this is the old guy that can tell the weather by what his knees doing. Then you can also have spinal compressions as well, which could cause, obviously, pain, stiffness, and muscle spasms in the back, or even the extremities. Yes, spinal compression. If you have, and again, it's local. If you have a breakdown in the cartilage between the vertebrae, you can have that spinal compression, not decompression, but compression, and that can cause, well, generalize the muscle spasms in the back, but also the extremities. You can have upper extremity spasms. Yes. Yeah. Because you think about it, you know, vertebrae are around spinal cord, right? So if you have a change in that structure that's supporting the spinal cord, you can have different, pressure placed in different areas of that spinal cord. Yes, it's compression. Yeah. So compression, as those vertebrae kind of impact or compress down. All right, so for osteoarthritis, what are we going to do? I'm going to get over to that page yet. What are we going to do for our osteoarthritis patients? Okay, treat pain. And this is more of a chronic type pain. All right, what else? Encourage weight loss. Encourage, ambulation. Could it say what type of activity? That weight-bearing, low-impact activity. Excellent. Yeah, we want to limit the activity that causes that pain. Okay, so if there's some type of activity that causes greater pain, maybe we need to try something else to improve that. Also, cold applications. With this type, we would provide cold therapy. But again, that needs to be prescribed. All right, so now rheumatoid arthritis. What's going on with rheumatoid arthritis? It's systemic. It's systemic, and you'll see bilateral what? Swelling, inflammation, pain. Yeah, it's going to be bilateral and symmetrical. It's a result of antibodies, so the body is actually attacking itself and attacking specifically the synovium, causing inflammation of the synovium and the synovial fluid. All right, what are the signs and symptoms of rheumatoid arthritis? We talked about a little bit of that, but any others? All right, what's the nature of the pain? Yeah, it's going to be more generalized. generalized pain, general pain. Also, well, you tell me, what else? Morning stiffness, fatigue, okay? Flu-like symptoms. So, fever, all right? Definitely. Well, it's not infection, it's our immune system is attacking the immune. So that's why we have a response like we would for an infection. But it's not an infection. All right, what else? So we've said morning stiffness, weight loss, symmetrical bilateral inflammation in the joint. And what are we going to do for that morning stiffness and general pain? All right, warm or hot, I guess warm heat. No, not warm heat. Warm moisture. There you go. Moist heat. All right. So recommend that they take a shower, and then what else throughout the day? Some type of warm, moist compression, compresses, warm compresses. And that's before any activity. If they just have a lot of pain throughout the day, and they may want to take another shower. But that moist heat is what's going to be the focus there. And then finally, you've got the joint deformity. Okay, and we've talked about that a little bit. Again, it's bilateral joint deformity, and it's going to be progressive. So early to moderate to late. Now there are medications, but not like that one-time fix and everything's good. All right, so we're going to stop. Yep, if it hurts, systemic, bilateral, and you use warm compresses, okay? Good way to put that. Yes. Let's see what else we got. I bet that would be helpful, wouldn't it? Yeah. I know. The warmth is going to facilitate the movement of the fluid out. That's the best answer I got for you. It helps to eliminate some of that inflammation and move that fluid out of the joint. All right, so let's look at some of the medications that will be used. Okay. Well, NSAIDs. What do you need to monitor for when you give a patient an NSAID? Bleeding, GI upset. Okay. So how could you help improve that or prevent the GI upset anyway? Not the bleeding part. Give with meals, snacks, something like that. With administration. Also, patients need to avoid alcohol when they take the NSAIDs. That could increase that bleeding risk. All right, now when we've moved into the second generation, okay, second generation NSAIDs, what are some of the things you need to be aware of when we're talking about the second generation? Okay, we're talking about our Celexa, Celebrex, not Celexa, I'm sorry, antidepressant, Celebrex. All right, talking about Celebrex, Arcoxia. What was the old one that they actually took off? Anybody remember hearing that? The Box. I think it's Box, wasn't it? They're looking at cardiac issues related to these medicines. Okay, you want to monitor cardiac function, monitor for dysrhythmias. Also, with these, you want to give with a full glass of water and also with food. Okay, so snack just like the first generation. Remain upright for 15 to 30 minutes following administration. The second generation NSAIDs. So Celebrex. No. Give it with food, because remember the GI upset issues as well with the second generation. So we give them with a snack or a meal, and then keep them upright for 15 to 30 minutes after administration. Usually it's dealing with, you need the fluid to help with the reabsorption. So yeah, then there's that. So that's always good too. So yeah. All right. So now let's move on to our glucocorticoids. When we give glucocorticoids, what could be, or what are some issues we need to kind of keep in mind? Risk for infection. Okay. So if I give a patient a glucocorticoid, what's its function? What is it doing? Yeah, it's diminishing the immune response. Okay. So if we don't, because the immune response is a good thing in most cases, right? Inflammation is not real fun, but the immune response is good to prevent infection. So we need to monitor closely for signs of infection. Also, what else can it do? If I say glucocorticoid, all right, hyperglycemia. So if a patient's already at risk for high blood sugar, so if they're diabetic, they've had a history of hyperglycemia with glucocorticoid administration, you need to keep an eye on that. Yeah, it's going to be pretty good. If I commonly you'll have even type 2 diabetics that are controlled with PO meds or whatever. They don't typically have to have insulin. They may have to go on insulin when they're taking the glucocorticoids. It's common. But you need to be mindful of that. When you walk in the room and the patient says, "Yeah, I'm diabetic, but I don't take insulin, so I don't need that insulin." Well, your blood sugar is now 300. Make sure that they're aware of the steroids. Also, if patients on long-term glucocorticoids, what do we need to make sure that they do? They don't stop it. No abrupt stops on the glucocorticoids. They need to be tapered off. Can really mess up the adrenal glands. All right. All right. Well, some of the major side effects involve the cardiac. Yeah, he asked about the second generation NSAIDs. They still have the GI upset, so I guess the risk for GI upset. Also the cardiac risk. Need to kind of be familiar, at least educate the patient on if they feel palpitations or have any heart changes that they can feel. They need to report those. But then they also need to be administered with food, or at least a snack, a full glass of water, and sit up for 15 to 30 minutes after. That was the second generation. Now, the first generation, all those are probably not a bad thing, but specifically the GI upset, so we take it with a snack or something. How many actually follow that when you take your Motrin or Aleve or whatever? Hopefully it's not rotting your esophagus. All right. Let's move on. Remember, this is the picture that I showed you. This is what the normal joint should look like. This is your osteo, and this is your rheumatoid. Okay. Maybe that helps bring it together. All right. So osteomyelitis. What is osteomyelitis? Infection in the bone. So what are we going to treat it with? Antibiotics. All right. From a nursing standpoint, what do we need to monitor for? All right. Signs of infection. And if we know we've got osteomyelitis, we want to look for what? Okay, worsening of the symptoms. So we want to make sure we're at least familiar with, or at least assessing, to make sure it's not getting worse. So what would be an indicator that it's getting worse? Okay, continued fever. Now you may have fever that worsens. In most cases, if the patient has osteomyelitis, they have fever. Okay, but if it continues for a prolonged period of time, even with antibiotics, but physically increased pain, it's not resolved or not responding as well to pain medicines. Also at the site, what am I looking for at the site? So say I had osteomyelitis in my knee. Okay. I'm looking for streaking. I'm looking for increased warmth, increased wet redness, increased swelling. You know, all the signs of infection get worse. Okay, that could be a sign that it is now moving and expanding in the space where the infection is occurring. So we definitely want to monitor that. What's a good way to monitor that expansion, or I guess the worsening of the infection? Mark it. Mark your boundaries. Okay, mark the outer edges, and you can see that redness or that swelling expand. I mean, this is a nasty, nasty infection. Treatment's going to be IV antibiotics. Usually, once they have osteomyelitis, it's, a long time, 4 to 8 weeks. And then commonly they'll have to follow it up with PO meds too, PO antibiotics as well. Now, what does this do to the actual bone? Or what can it do? It can weaken the bone, and it can cause deformities, and it also can cause necrosis inside the bone, okay, of the bone tissue. So what do you think that's going to put us at risk for? Falls, potentially cellulitis, because it can expand out into the tissue as well. But falls is going to be the big one there. It's weakened the bone. So what are they commonly going to do to prevent fractures or immobilize the extremity? Okay, so if it's in the knee, you can probably put them in a knee immobilizer or even a walking boot or something. Well, it has to be a long walking boot, but usually a knee immobilizer or something like that. Depends on the prescribed activity. That's going to be kind of a physician call. If there's a lot of danger for further injury, they may actually ease off on some of their activity. It can cause deformities, but more importantly, it's going to change or it can cause necrosis of the bone tissue. It depends. Often, and sometimes those were our longest. Those were some of the patients we would have for the longest periods of time. A lot of times they had debilitating injury that lingered even after it improved. This is a very, very hard infection to get rid of. And a lot of times they'll think it's done and then they'll have to come back. Commonly, and this is bone. So they're going to be really hesitant to really go in and take away a lot of the bone, a lot of that necrotic tissue. But that's usually what has to happen before they can get it to really start improving. All right, questions? Well, not always. I mean, it depends on the injury, the severity, and then more importantly, the physician's order. So follow whatever activity the physician orders. Yes. Yeah. I mean that's general antibiotic therapy, that kind of thing. We're not going to ask you what type of antibiotic. I mean, all right. Well, it's not always systemic, but it can be quickly, because you think about the location. You're inside the bone where there's an easy access to that blood supply, so it can quickly become systemic, very quickly. A lot of times these patients will go into sepsis. All right. Let's talk about that. Let's move. Same thing with, when you've got a joint replacement, okay? All right, so I've had a patient with a hip replacement. What's the post-op care that should be provided? Okay, abductor pillow. What is the abductor pillow going to prevent? Yeah, well, hip flexion is that, well, it keeps it in the, now remember, abduction. What is abduction? That's moving out, all right? Adduction is moving in, right? Adding toward the body. So the abductor pillow is going to keep it, it's preventing adduction, okay? Adduction is the real danger with following a hip replacement, because you think about, okay, if my joint's here and I move it in, it's easy for that joint to pop out, or the head of the femur to pop out, okay? So that's what they're really wanting to prevent. Now, you could easily cause a dislocation moving out as well, but that adduction is what they really want to prevent. So they do an abductor pillow to keep them in that position. Does that make sense? Yes. So, okay, so my arms or legs, all right, I put an abductor pillow in between to keep me from being able to bring the legs together. That's adduction. Look, okay, the abduction pillow is to prevent adduction. Yeah. Because we don't. Yes. Yes, we don't want we don't want the leg to move inward so that the joint could pop out. Does that make sense? Or dislocate? Yeah. Yeah. All right, so we want to prevent joint dislocation, so we keep the patient in an abductor pillow to prevent adduction. All right. Regardless, you just want to prevent joint displacement. All right, and then also, all right, so you've got them in the abductor pillow. What else are you going to do? Okay, no flexion greater than 90 degrees. All right, so there you go. All right, 90 degrees, right? Okay. We don't want the butt to go down lower than the knees. All right. If it does, then you can have, again, dislocation at the hip. Okay? So when would that come into play? When a patient is sitting anywhere. All right? So we want to make sure that the bed is high enough so that when the patient sits, we don't drop down lower than the knee level. All right? Also, using the restroom. All right, what could we do? You know, I don't know. Most of these toilets we've got are not going to be high enough to keep the patient from going down lower than 90 degrees. So you put on an elevated seat. Okay, an elevated seat. That's important. You know that. But as a nurse, make sure that that is available. Make sure that that's ordered. What now? Yeah, fractured bedpan. You know, and it may be that a bedpan is the way they have to do it. But anyway, just make sure that the seat is elevated to prevent that, greater than 90 degrees. Which I'm trying to say. Okay, we went into this last night, right? This is my 90-degree angle. That would, I guess, that would be a lower angle. You don't want the angle to go below 90 degrees, I guess. y'all get the point though, right? You don't want the butt below the knee. That's the easiest way to describe it. 90 degrees is the max. Okay. Also, head of the bed. What do we need to do with the head of the bed? Yeah. 30 to 40 degrees. We don't even really want to set them up to that 90 degrees unless we can, unless we just have to. But 90 degrees is the absolute max. For meals, we want to set up 30 to 40 degrees. Okay. Yes, they can, but you need to be careful and make sure that they don't sit in that position for too long, because you can cause the hip contractures, or even usually it's going to be painful, so they're not going to want to. In most cases, your hip patient is going to want to be flat or pretty close to flat. All right. Now, if I'm going to turn this patient, how am I going to turn them? To the unaffected side. We don't want to turn them onto the surgical hip. Is there a question? All right. You don't want to turn them to the surgical hip. All right. You got to do, well, you just got to picky battles. Yeah, you're not going to want to turn them all the way over. You're gonna use pillows to reposition the weight, or change the weight distribution. Now, I mean, and even with this, you're gonna turn. Okay. The main thing is we want to redistribute that weight. So to the side and back. Depends. They'll try to start at least doing range of motion, but controlled range of motion. So they're not going to get them up. Usually, yeah, that first day post-stop, they're going to want to start at least doing some type of range of motion. Physical therapy usually does a lot with the initial activity, the initial range of motion exercises and things like that. Yeah. Okay, so when we are turning, how often do we want the patient to be turned? Yeah, at least every 2 hours. Okay. Definitely don't let the patient, lay in the same position for more than 2 hours. Okay. All right. So, and that's an important nursing action. Make sure that you are initiating that turning. Make sure that you are ensuring that it's done by somebody. Okay. Yeah, it's either back and then to the unaffected side. Basically back and forth. Now, even when they're on their back, you can still position them. But yeah, it's back to unaffected side. Yeah, you would want to make sure that you don't move the leg in, for sure. Typically post-op, the physical therapist is going to be the one that does the range of motion, especially on those joint replacements. But if you have orders for it, just make sure you do not adduct that extremity. All right. What else we got here? Knee replacement is going to be similar in the fact that it's not, the general care. You're not going to have to worry about an abductor pillow. This is the patient that will have a CPM machine almost always. They want that continuous movement of the joint, and usually, they may prescribe 4 to 6 hours a day, or maybe 4-hour increments every, 2 or 3 hours, just depending on the doctor's orders. Alright, so we're going to move through some of this kind of quickly. As far as the knee, nothing in particular about, it doesn't need to move laterally, or it does. You don't need to have any sideways movement of the knee joint. A knee immobilizer is usually going to be used if they're ambulating, getting out of bed, that sort of thing, unless they're in that CPM machine, in most cases. All right. Any other questions? Okay. Back issues. If we have any type of back or spinal surgery, what are you going to want to monitor for post-op? Okay. Neurovascular status. Not only neurovascular as far as the 6 Ps. Okay. Well, where are you going to assess the 6 Ps? Everywhere. All right. All the extremities you need to assess the 6 Ps, because just because they had the surgery at this portion of the spine, you may have nerves that are kicking off in other places. So that may be where you see the issues. But 4 extremity neurovascular status checks. Also neurological checks. All right, you need to do neuro checks. At least, as far as the numbers go, the physician's going to give you a specific order. At least every 4 hours. Probably more often than that post-op. Yes, spinal fluid. So we're going to look for drainage, right? Spinal fluid drainage, what is that going to look like? Okay, clear with the halos on the dressing. All right. What else? What else are we going to look for? Especially related to the drainage. Okay. Yes, you're going to look at the drainage for signs of infection. What else could be? Blood. All right. Excessive bleeding. Now, a lot of these spinal surgeries, you're going to have blood. And, you just want to make sure that it's not excessive. All right. What else? Okay. Yeah. Infection. So the surgical incision itself. Pain. Okay. Headache. And what could the headache indicate? It could be a CSF leak. Okay, so even if you don't see necessarily the drainage, if the patient's having a lot of headaches, and usually those CSF headaches, the CSF leaks, the headache doesn't really go away. Even if we give, pretty good pain medicines, they'll have that lingering headache. What else do we want to make sure that they do post-op? Void. Void. Absolutely. Make sure that they void post-op. Anything gets hit, nicked during the procedure, you have some type of inflammation that causes swelling that compresses on a nerve, or if they had a Foley in the OR and they had some type of irritation in the urethra or whatever, they could have have difficulty voiding. All right, what is the cause of gout? Okay, uric acid, buildup of excessive uric acid. All right, and where are you commonly going to see the signs? The big toe. All right, the gout is going to affect the joints. That big toe is going to be that first one that you see most commonly. Excruciating pain. Yeah, and it comes. There's going to be different. They'll have commonly have acute episodes, but then eventually there may become a chronic, lingering pain that just doesn't really go away. All right, so what is our treatment for gout? What do we want to encourage? Chicken and water, yep. Increased fluid intake, all right. And we want to avoid what? Okay, alcohol, red meat, what else? The organ meats, yeah. Foods high in protein, okay, the purine, well, we want to increase, yes, there you go. All right, say that again. Everybody hear that? Organ meats, wines, and aged cheese. It's high in purine. Things that are in wine, aged cheese, and red meats. Yeah, organ meats. All right. I think, yeah. Yes, beans also. All right, so attacks may be precipitated by trauma, diuretics, increased alcohol consumption, or increased, an increased purine diet. So those foods that are high in purines, high proteins, mainly. Well, it dehydrates. Yeah, that's the main thing. I mean, if you have excessive diuretic use, you can become dehydrated. If they don't replace the fluid, or all right. Now, Lyme disease. Lyme disease comes from a tick bite. Bullseye lesion. That's a hallmark sign that you need to be familiar with. Bullseye lesion that is round, oval, flat, or slightly raised rash. So erythema migrans. That type of rash is what you will see. And in the U.S., commonly it's going to be in one lesion. It's called the bullseye lesion, basically. Lasts 2 to 12 weeks after the tick bite. And if they don't stop it early and get PO antibiotics on board early, then it may move into stage 2 or 3, and it's a lot harder to treat. Or stage 3 is almost a kind of a chronic, permanent type of issue. Stage 1, yeah. I mean, it's going to be PO antibiotic. It's a typical PO antibiotic regimen. Stage 2 is when they have to do the IV antibiotics. It's going to be long term, a month or 2, depending on how severe. Going back to gout. All right, you need to be familiar with these medicines, okay? Some of the medicines that we use. You need to know how they work, specifically these chronic ones. Allopurinol is used to limit uric acid production. Uric acid, it limits uric acid production. And we want to closely monitor for liver failure. All right. The second type is a removal agent. So uric acid removal agent, commonly you'll see Benamid. And what's doing the removal? Well, the kidneys. Okay. So to prevent extra strain on the kidneys, we want to encourage fluid intake. And then also monitor kidney function, monitor for kidney damage and failure. The second one, the uric acid removal agent, Benamid. Benemid. So the Benamid is going to remove uric acid, facilitate removal. The Zolaprim is going to reduce production, uric acid production. All right, what's the diet going to be? Low purine diet, where we limit organ meats, okay, wines, aged cheese. Another one we didn't mention, fish, commonly fish, specifically like shellfish, sardines, those types of really fishy fishes. Yeah, you definitely don't want those. Avoid those. Just in general, avoid fish unless you breathe it. It's okay. Just in general, you don't want to risk it. Chicken and water. Yeah, definitely avoid alcohol. Yeah, all that good stuff. All right. Osteomalacia? Yeah. All right, osteomalacia is going to be a bone density issue where we have demineralization of the bone. So calcium resorption, or removal of the calcium, and it's not replaced with proper density. It's replaced with spongy, compact bone. It becomes soft. Osteoporosis, you have a calcium deficiency. With osteomalacia, you may have enough calcium, but the body is not using the calcium appropriately. The side effects, or I guess the complications, are going to be similar. Yes. Well, no. Yeah. Yes. Ineffective bone density or bone growth. Okay. So ineffective movement and storage of the calcium inside the bone. So you lose that density and strength. This is also referred to as rickets in kids. Yeah, and that's the main issue. The underlying problem is the vitamin D deficiency in most cases. So basically, we can have all the calcium we want, but if we don't have the ability to use and store it, not even really use, but store that calcium in the bone, yeah. You're at risk for falls, fractures, all the good stuff. All right. All right, now, sprains and strains. What's going to be the treatment? ROS. Okay. So what's ROS? Rest, ice, compression, and elevation. Okay. For as a general rule, most of these sports-related injuries, that's going to be your treatment. Okay. Cold therapy, absolutely. You would only do cold therapy for that first 24 to 48 hours. No heat during that first 24 to 48 hours. After that, they may prescribe some type of heat treatments, but definitely no heat during that first 24 to 48 hours. We want to elevate the extremity, reduce swelling. And if they decide to do surgery, what are you going to closely monitor? 6 piece. Yeah. Incision sites, and all that good stuff. We got a lot of good stuff in here. All right, dislocations. Pretty much the same thing as fracture, just in terms of the treatment. The nursing treatment, you're dealing with pain. The signs are going to be the immobility, the change in the joint movement, range of motion. You'll have physical signs where you can look and compare one side to the other and see if there's an obvious deformity. In most cases. Then it's going to be, so your nursing intervention is pain relief, joint support, so we want to make sure that we immobilize until they can reduce, and then probably immobilize even after. depending on what the physician orders. And then treatment, open versus closed, it's the same as a fracture. Okay. All right, so fractures. I'm not going to throw up a bunch of bones and say, okay, what type of fracture is this? You know, that's not what I'm worried about. You do need to be familiar with the definitions of, you know, what's an open fracture? Skin's been broken. Okay, you've had tissue damage that results in break in the integrity of the skin. Okay, so that's open. Closed. Well, skin's not broken. All right, nice and easy. What's the differences between the two? So if I had an open fracture, more risk for infection. We've introduced the bone, and we've introduced those tissues to the outer world and the infection that goes along with it. All right, so that patient is at much more greater risk for developing osteomyelitis, even sepsis, even local infections, you know, even tissue infections. But that's the patient that's going to be at risk for infection. All right? The closed fracture, it's severe. You know, you can have a very severe closed fracture. You can have a crush injury. But that patient is not as likely to develop osteomyelitis. Now, yeah, they will be, you know, they commonly have osteomyelitis, but that's not as often as the one that has the open injury. All right. So, symptoms of fracture, you need to be familiar with those. All right. You also need to know about the wound or the fracture healing, that process. All right. So, when does the healing process begin? Immediately. Okay. It begins immediately because immediately we start to have bleeding. All right. So we have bleeding, hematoma formation. So that bruising that you see, not always a bad thing. So hematoma formation is going to be your first step in the healing process, and at the side of the fracture, that hematoma will form and begin to heal. Followed by granulation, tissue formation, callus formation, ossification, and then consolidation. All right, so complications. We've had a fracture. Now, what are the issues? Okay, so compartments. How are we monitoring for compartment syndrome? 6 Ps. You look at that swelling and the tension. You know, commonly, if you have a patient with compartments, that extremity looks so swollen that if you took a pin and stuck it, it would just pop. I mean, it's that tight, the swelling. Do what now? Take them to surgery. Yeah, they'll take them to surgery. If they deem that there's a compartment syndrome is occurring, and they're going to take them, it's an emergent procedure. They get them down pretty quick, and they are basically just cutting through tissues to relieve that pressure. It's awful and painful with them. All right, so we want to prevent that, right? So we prevent that by doing good nursing care and monitoring the 6 Ps. You know, we've got a patient, they're asleep, they've got a severe arm fracture, and maybe they put them in a cast. Well, you know, they're resting real good. I don't want to wake them up. Okay, I don't want to check the 6 Ps right now. We'll let them sleep a little bit longer. Yeah, I know that the arm's down by his side, but it looks like he's comfortable. I don't want to move that arm around too much. Well, you don't assess this, and it won't be long before swelling occurs. If they're in a cast, that swelling occurs inside that cast, and often you can't see it. Okay? Until their fingers puff up like they've got a claw hand, or they start having swelling and tissue, basically tissue that's spilling out over the calf. Monitor these extremities carefully. Once it gets to compartment syndrome, that's a huge complication. All right, fat embolism. What's going to be my first sign that a patient may be suffering from fat embolism? Altered mental status. All right. I've got a patient that had a traumatic accident. They had an MVA, a femur fracture, maybe even bilateral femur. A lot of stuff going on. They're on a lot of pain medicine. I walk in the room and you ask them where they are, and they tell you they're at home watching TV. Well, that's a change in mental status, and you better start figuring out if they've got some type of embolism going on. You suspect that's the issue until you kind of prove otherwise. It could be not only a fat embolism, but also a thromboembolism. Okay? Anywhere that you have a fracture or skeletal injury, there's going to be bleeding, there's going to be clotting. And those clots can move in a hurry. All right, also you've got the infection osteomyelitis we've talked about. Hypovolemic shock. All right, what's that going to be a result of? Losing blood. Again, these fractures and these significant injuries, they bleed a lot. Okay, so you've really got to monitor for hypovolemic shock. And what it's going to be? What are some of the indicators that hypovolemic shock may be occurring? Okay, tachycardia and hypotension. So elevated heart rate, drop in blood pressure. Yes, initially. Eventually, all of it will start. But elevated heart rate, drop in blood pressure. So if you've got a patient that even, whether they have normal blood pressure typically or even high blood pressure, if you have, maybe you've got a patient that's normally hypertensive and they came in with a blood pressure of 160 over, 95. Well, suddenly the blood pressure is all of a sudden back to normal. Now, there's two things that kind of could be going on here, right? Maybe we relieve the pain, or maybe we've got significant drops because they've bled out a lot. So if they're still screaming, they're still hurting, but their blood pressure is now, 95 over 60. Heart rate's, 180, 200. Usually if they're in that much pain and their blood pressure is dropping, that's not a good thing. Okay, so you need to start considering there may be hypovolemic shock, or at least they're moving in that direction. All right. Now, you come across, if you're out somewhere and a patient has an obvious fracture, obvious deformity, even if you suspect there may be a fracture, you splint them where they lie. Okay? Find something. It doesn't have to be a nice, pretty splint that you pull out of a Pyxis. Just something that's going to immobilize and prevent further damage from occurring. Okay? Maintain as normal body alignment as possible. Now, does that mean we're going to go in and reduce it? No. You don't reduce it where they lie. You splint it where they lie. All right? You're not trying to put it back in place. All right. Assess for, changes in neurovascular status. Okay. Elevate the extremity. Do everything you can to get that extremity as elevated as possible. Administer pain medicine after the risk of head injury is ruled out. We don't want to cover it up. You don't want to cover up a major issue. All right. Just be aware, okay, if we have an open reduction, what does that mean? They had to surgically realign the bone. Okay? Fixation means, they had to do something to fixate, to maintain that alignment. If it's internal fixation, that means they put a rod, they put a plate, they put screws. They did something to realign and keep or stabilize that bone in proper alignment. Okay? Now, if we have a closed fracture, but they have to do an ORIF, or an open reduction internal fixation, what new problem do we have that we really need to monitor now? Infection. So yeah, it was a closed fracture, but now that we've opened it up to that increased risk of infection, right? Pretty much. Well, if it's an open fracture, they're going to almost always have to do surgery. They're going to have to go in and do a surgical fixation. If it's a closed fracture, they may or may not have to go in and surgically repair. But if they do, regardless of whether it was a closed or an open initially, we've introduced the risk of infection if that increased risk factor goes up. All right, with traction. Well, all right, so regardless of the type of procedure, and this is closed reduction, but open reduction is going to be pretty similar. Elevate the affected extremity, apply ice as ordered during the first 24 to 48 hours. Constantly assess the 6 Ps. I'm not putting a number on it. The physician may, but you don't. If the physician orders neurovascular checks Q2 hours, you can check it every hour. Don't be scared to go in and, pinch some fingers and check cap refill. That's okay. But at least, do what doctor orders. So. All right. If you notice a very strange odor, awful odor coming from a cast, okay, what do you need to do? Recommend that they come in and they can take a look at it. Okay. There's a good possibility that there may be some infection going on. And usually it's a pretty obvious odor. It's not like, they just had a sweaty cast for 2 or 3 months. But regardless, they may want to go in and just replace the cast and check it and make sure. Don't stick anything inside. Make sure that they're not taking coat hangers or back scratchers or whatever else they can find. Pencils, pens, they like to do that too. Scratch underneath. Well, what happens? They scratch underneath, they cause a laceration, gets infected, and then we got a whole new set of problems. Encourage protein, iron, minerals, and vitamins. Helpful wound healing. And also bone healing. There's your open reduction. There's your external fixation. Now again, this is doing the same thing as the internal fixation. We just have the rod outside. Okay, so they didn't put the plate or the hardware inside. The hardware is outside. We have skeletal pins that are inserted, and then that's the way we can keep that immobilized and in place. All right, skin traction, skeletal traction. What's the key here for traction? What is our nursing care? Okay, always, always, always ensure that the weights are hanging freely. All right, don't touch them without an order. That's another thing. We don't want to add weight. We don't want to take away weight unless we have a physician order. If we have to move the patient up in bed, how are we going to do that? Carefully. We're not going to remove weight to move the patient up in bed. Okay? So, test question, you're not going to remove the weights to pull the patient up in bed. You would refer to the physician without an order. You may have a physician order that says, all right, hey, look, you can move them up in bed. You can take the weights off for bathroom privileges or whatever. But that's going to be a specific order thing. Yeah. Also, if the extremity has moved, we rest on another, something that would take the weight off of the traction. So, for instance, Buck's traction, it's skin traction. You've got the leg wrap, traction's in place. Well, the patient has slid down to the edge of the bed, and now the foot is resting on the edge of the bed. What do we have going on here? Yeah, the weights are not hanging freely. And the weights may be hanging freely, but they're not that patient is no longer in the traction that was ordered, because the weight's not going to be the same. Usually you've got an order, but you want to make sure in a question, if it doesn't say you've got an order, you don't have an order. In most cases, you're going to have some type of order, standing order, something that would allow you to at least do that. The key there, if you need to move them up in bed without an order, you're not going to remove the weights to do that. You're just going to move them with the weights still attached. Yeah. All right, that's it. In most cases, you're going to have an order or some type of standing order. We would have orders that said weights from this range to this range, and you can kind of use and manipulate as the patient tolerates or whatever. That was with an order. All right. So if you've got skin traction or even skeletal traction, make sure you care for the exposed skin with padding and dressings. Make sure the heels aren't touching the bed or in pelvic or buttocks traction. Never remove from traction without an order. Treat pain and provide comfort measures while maintaining correct alignment. The thing you would add for skeletal traction, pin site care if ordered and as ordered. Regardless, you're going to want to closely assess for signs of infection. You're going to assess for drainage from the site, from odor from the skeletal pins. Commonly, they'll use sterile water and peroxide, some strength, usually half strength. But again, that's with a physician's order. And then make sure that the ropes and the weights are hanging freely. All right, amputation. All right, amputation, removal or severing of a body part. Okay, it can be done on purpose, or surgically, or it could be a traumatic amputation. Okay, what's one of the key differences then if it's a traumatic amputation versus a planned surgical amputation? All right, risk for infection, absolutely. Yeah, you're going to know beforehand. You can plan for it. You can provide pain medicine, all that good stuff, so that helps. Also, the patient can mentally prepare at least to some degree. Okay, that's a huge aspect of amputations. The mental and psychological preparation prior to the procedure. Make sure that the patient is aware of what's going to happen. Make sure they know why. Make sure it's clear. This is a removal of whatever it is. You know, it's not like it's. Just make sure that they understand. Give them the opportunity to voice any fears and concerns. And if there are fears you can alleviate, you can do so. But don't tell them, hey, everything's good, you're going to be fine. I've seen this done 100 times. Everybody's okay with it. Don't do that. You know, be respectful and mindful of what they're feeling, because it's a major thing. Don't tell them everything's going to be okay, because you don't know it's going to be okay. Tell them that if they say something that's factually incorrect, you can kind of alleviate that fear. But definitely non-confrontational, and you don't want to confront them about something. Y'all know all this stuff, right? How to pick out appropriate ways to speak to patients, whether you use it or not. All right. One other thing, and I didn't really mention it. Yeah. One of the things I didn't mention. A lot of times there's some cultural considerations, and I meant to say it the other day. Certain cultures require the amputated limb to be stored for burial with the body, down the road. But also, they may bury the limb immediately. Okay, that's part of their religious or cultural customs. You need to ask that prior. Don't wait until the amputation is done. They start asking, "Where's my leg?" And well, it's in biomed. I don't know. I mean, make sure that that's a question that you ask ahead of time. Don't assume that they're not going to want to do something with that limb. Okay, make sure you ask that up front. Major lawsuits come out of that type of stuff. Okay, so make sure you ask that ahead of time. You're talking about like I don't know. Hopefully they're probably going to try to ask a family member. I don't know. That's going to be one of those higher up, I guess. I don't know. It needs to be considered though, for sure. So assess those religious and spiritual. I'm sorry. Well, yeah. I mean, we hadn't really touched it, but for sure, make sure that they've marked the limb clearly pre-op. That's part of that nurse's role in ensuring that patient's prepared for surgery. Make sure that they clearly mark the limb. I know we had to have a physician's signature on the limb. They initially had initials, and sometimes the initials they wanted a full signature of the physician prominently on that limb before they went down for an amputation. If it's bilateral, make sure that they've got bilateral signatures or whatever marking that the institution requires. That's going to be institution specific. Yeah, that's another area that lawsuits come into play. Also, the location, we talked about that a little bit. The location is going to be usually in relation to the joint, or really almost always, especially when you're talking about the limbs. Below the knee, obviously below the knee joint. Above the knee joint. This articulation is going to be at the joint. Commonly, they're not going to go at the joint. But if you have a traumatic amputation, it may be that that's where the amputation occurred. Right? Just remember, this articulation is going to be that at the joint level. All right, what's going to be one of the major, if you have a surgical or a traumatic amputation, but specifically a traumatic amputation, what's going to be one of the key concerns you have when the patient comes in? The risk for bleeding and hemorrhage. Okay, that's going to be one of the major. It doesn't matter where the amputation occurs. There's major bleeding and hemorrhage involved with amputation, regardless of where it is. Obviously, some are worse than others, but you need to be mindful of that. Even in the case study we talked about, the fingers. You lose fingers, you're still at great risk of hemorrhage and bleeding, even with those fingers and toes. All right. So that's amputation. Post-op. Again, you're still monitoring for complications, including the hemorrhage, the bleeding. Good wound care, suture care, very important. First 24 hours, you're going to elevate the foot of the bed to reduce the swelling to the stump. After the first 24 hours, they may ask that you lay the head of the bed flat, okay, and also the may or may not be the actual limb itself. You still want to keep it elevated to prevent the swelling. However, they may also put the patient in the prone position. This is to help build up those muscles, the anterior muscles in the legs, and then they may continue to add hard surfaces, things like that, for the stump to to be pressed on. What they're doing is getting it ready for prosthetic fitting. Okay. If the patient is not, if the stump is not prepared for the prosthetic, there's going to be a whole lot of pain involved. The risk for breakdown is pretty high. And then also, it's not going to be in the proper shape. Okay. Now, surgical dressings, and I didn't hit this as much as I needed to. Those surgical dressings are very, very important related to the stumps. There are specific ways that they want the stumps to be wrapped, depending on the location. But regardless, they use a figure 8 technique. And following the initial removal of the surgical dressing, they're going to have the stumps are going to need to be wrapped 3 times a day. Okay. Yeah. This figure 8 pattern. After that initial dressing is removed, they're going to start doing the serial wrappings to make sure it helps with the molding of the stump. Yes. All right. Also, in your education, you need to make sure that you educate the patient on inspection of the stump and the incision and suture. They need to do that, and commonly that's going to occur after the sutures and staples have been removed. That's when they really kind of focus in on the inspections. But you definitely want to make sure that they're inspecting the stump daily. Okay, they'll do mirrors. They usually have mirrors with like an extension, kind of like a big dentist mirror, that they'll have with an extension stick or whatever that they can use to maneuver around the stump and inspect for any wound breakdown, any signs of the wear and tear. All right. Continually assess the psychological, the emotional well-being of your patient as well. They're okay with it going in, but once they get out, there's still going to be that grief process that they have to go through. Okay. Also, they may be okay with it after, but then as they are having to learn how to redo things or change some of the behaviors, and it starts to set in a little bit, and there's a lot of psychological support that they need. So, you as a nurse, listen to any issues that they have. Give them provide an ear for them to listen, or for them to verbalize those concerns, the fears, the issues. You do something, but also you can delegate out. Whether it's a pastor or support groups, those are good. Put them in connection with support groups. Just seeing somebody else in kind of a farther along in the process. Does that make sense? So if a fresh amputation, they're going through struggles, but if they can see what the outcome could be, it helps a lot. All right, crutch walking. All right, this was one of the things that we talked about. We couldn't exactly decide. I looked it up in several places. Crutch walking, you are to be on the affected side. Okay, that's what the Saunders NCLEX review book says. All right. So the affected side is where you will assist the patient with crutch walking. Now, if the patient has a cane, the cane is going to go on the unaffected side. Okay? When I saw it, even in my notes yesterday,
I looked at it, I was like, is that right? But yes, I did verify. The affected side when you're doing crutch training, the cane goes in the unaffected side. And even, I didn't see a specific thing on the canes as far as your support, but you would probably, you would provide support on the affected side as well, with cane. All right, when you're doing any type of crutch training, any type of mobility training, what's going to be the key there? Safety. Okay, make sure that they know how and have been trained on crutches before they are able to use it. All right, make sure that they know how to use a cane before you give them a cane. Okay, make sure that training is there. Very, very important. And then walkers. Stand adjacent to the client on the affected side. Instruct the client to put all 4 points of the walker flat prior to putting weight on the walker and stepping forward. Okay. The affected side. Stand adjacent to the client on the affected side. All right, what questions do you have? Anything and everything we talked about today? Or